conservative management of fractures in 2013-14 was accepted to be presented as a symposium. Generally, the subject is not acknowledged, and I'm very happy, and I'm more than happy that the hall is full and overcrowded, because I was told that a symposium is granted only if there are 20 or 20 more people expected. And I am grateful personally to each one of you to be present here, to listen, to lend your ears to this subject, which is very apt today for conservative management of fractures. It's very, very important. I've been thinking about this subject for a couple of years, and it has been given a shape today, this afternoon, and we have 8 stalwarts from all over the country who will be presenting their work, and you will be listening to them as how a conservative management of the fracture works. And I happen to be the first speaker as a convener of the symposium. So with your permission, Mr. Chairman, I take the podium.
As you know, Professor Yadav is proponent of orthopedics, which is useful for the majority of the Indians. And I think he represents the Indian school of orthopedics in comparison to British and American school of orthopedics. Professor Yadav.
Well, I have given a preamble. Can I have the slides, please? Without losing time. Well, I'm very happy once again that we have so many listeners, and I'm sure it will come to the expectations of the people. The world is going towards open reduction and internal fixation. It is very good, there is no doubt about it. I repeat, it is very good. Fractures of the ankle, bata diya bhai. Thank you, sir, for your comments. हम तो सबसे छोटे हैं भाई. Well, the management, looking back and looking ahead. I thought of this subject for presentation, looking back and looking ahead. This is the place I come from. It is a village, my native village in Haryana near Rewari, where I have been working for the last 14 years. It's a charitable institute which... Now, fracture healing is a natural process. Let us at no point of time forget that it is an unnatural process. Whatever position the bone ends are, it is bound to unite unless and until there are some defenders which will come in the way, whether they are local or they are systemic. It is a highly organized and complex biological event with an intricate and well-controlled series of cellular and molecular events. And let me tell you at this point of time that still we do not know how a fracture heals. The same type of fracture, the same surgeon, some heal, some don't heal. Hence, there are a lot of factors hidden behind the screen which will come out tomorrow in the form of acceptance that these factors control fracture healing. That's why I said till this date, till this afternoon, we do not know how a fracture heals. Exactly, we do not know how a fracture heals. However, the two components which are in our hands have never changed and probably will not change. Like in a compound fracture, surgical toilet and adequate wound excision will never change. Howsoever, number of selines and mycines will be developed in due course of time. These two things will be mandatory and obligatory. Similarly, adequate fracture reduction I'm not talking anatomical. They used to talk about 20 years ago anatomical fracture reduction, but I'm talking adequate fracture reduction and stable immobilization, not rigid. Stable immobilization, which was achieved by POP and implants to restore reduction and immobilization till the nature does its job. And main thing is preserve biology. We had forgotten biology in between 70s and 90s, but we have come back, and that is why even in surgery we are leaning towards minimum invasive surgery, and the indication is to achieve biology. These are age-old things, good old 4 stages, which all of us know very well, and good old 4 major tissues which take part in the formation of callus. There are certain impediments in fracture healings which may be local or which may be systemic, and for that we will need a research tomorrow to come to the point of acceptance. Now coming to the point, close reduction and POP application, friends, is a dying art. It is not a dead art still, till this afternoon it is a dying art, and it's extremely unfortunate, particularly for the youngsters sitting at the back, standing at the back, that POP is totally compromised. Open reduction and suitable fixation is a windstorm. My younger colleagues feel that fixation is healing. Friends, fixation is never healing. There are many factors which take place. Rather, fixation at times may be impediment to healing, and fixation ये नहीं कि हर fracture को fix कर दिया जाए. You will really fix the fracture. Surgery is good. I am a surgeon. I also know how to do surgery. Surgery is good, rather very good. But indiscriminate surgery is very bad. This will be my carry home message I am giving in between. That indiscriminate surgery, without knowing what you are doing and how you are doing, fix karna hai, you will definitely screw the patient. There is no doubt about it. X-rays are shown only post-operative. It's not only limited to fractures. In any of the conditions, including THR or TKR, generally the author will present an post-operative X-ray, that's all, and switching on to the next patient. Friends, orthopedics is a speciality where you have to show your long-term results, including the very important part, and that is the functional part of the patient. We require function. We do not require a good X-ray. As a matter of fact, if I take a sentence here, that people take more time in interlocking, nailing and other procedures to show a very, very good post-operative X-ray, not knowing that the surgery goes for 4 hours and the bone ends are being denuded of its vascularity, which will land you up in a non-union. A long follow-up, very important message, a long follow-up and a proper record keeping. These days, it is unfortunate that even in medical colleges and other teaching institutions, there is no proper record keeping. Why not? And when we stand in the court of law, then the advocate asks, doctor, do you have record? What time the patient did you do? How long did you follow up? And the eyes are vertically down in the court that you do not know because you don't have a record. It's extremely important. बहुत ज़रूरी है. Sometimes, as I said, we cause more damage to the vascularity. We cause more damage to the biology. which is the central idea, which should be the central idea of a surgeon to operate. Do operate, but do not cause any harm. Hugh Owen Thomas teaching his nephew, Robert Jones, how to reduce fractures. Hugh Owen Thomas made a pavement in orthopedic surgery, which Sir Robert Jones had made a highway later on that pavement of modern orthopedics. Now, this was a case done by me in 1964 when I was a postgraduate student. And you see here that was the picture. Patient came in the night. And this was done in an ordinary plaster of Paris, जो हम पट्टी पे फैला के आजकल the youngsters sitting at the back, they must not be knowing what is that white thing, white looking thing. Some of the people they ask, and if they don't ask today, they will ask tomorrow if the present trend continues. That, sir, what is that white thing you are seeing there? That will be the saddest day of the specialty of orthopedic surgery if plaster of Paris goes out of picture and becomes a history. That was the picture. If you put plate and screws over it, it looks like open reduction. And why not? Why not learn the art? Here, this patient was asked that it will cost 1,50,000 rupees for fixation. We treated him in a plaster, and the man is having a very good function. Augusto Sarmiento had been fighting throughout his life, and in any CCOT meeting, they will have the maximum people for Augusto Sarmiento, but after the talk, वही घोड़े और वही लगाम, कोई फर्क नहीं पड़ता, कोई फर्क नहीं पड़ता. So we should learn the art as early as possible. Otherwise, it is possible we may not be able to leave behind any legacy for the youngsters. You had seen these era, stable, to rigid. It came for about 20 years, vanished, back to stable. Back to some movement at the fracture site for healing, micro movements, stable fixation, which can very well be achieved in a plaster of Paris, if well applied, if one knows the art. Now things like this, look at this X-ray. I like to draw your attention to this X-ray. Even if you leave it alone in a Thomas's splint, it will unite. It will unite, maybe a little shortening. Now look at what the patient had. If this was done, I did not know because the X-ray I couldn't count the number of screws because it was not in the extent of the X-ray. And look at that. Look at that. It became loose, then somebody put an external fixator on this plate. And that is the thing. The patient has to pay the price for rest of his or her life. It's really a, look at that. Somebody is very fond of this type of a fixator. And patient came to me like this and we did an abduction. Bone is not to be bullied. Another message. Bone is not to be bullied. It's a dynamic structure. It should be allowed to. Bone says, doctor, leave me alone. But no, how can I leave you alone? I cannot. Bone is requesting the orthopedic surgeon, sir, leave me alone. But no. Look at these. Complications are there in every surgery. Not only in orthopedics, but in any surgical procedure where you put a knife. Complication shall always be there. If anybody says in not my surgery, there is no complication, one has to think twice. But indiscriminate, I use the word indiscriminate surgery and low quality implants. Sometimes you remove plates and screws which are very low quality, and we in India have no procedure to find out which implant is good and which implant is bad. Look at the osteoporosis. This is a condition which is usually, invariably overlooked by the surgeons in fixation. But it will remind you, and my bad patients may not come back to me again. Hence there is no record. Sir, these are the ones. Balanced technology is very good, and we have to leave behind a legacy for the youngsters to remember that we have a generation ahead of us. Plaster of Paris, I have already said, very good. Splints are very good. Youngsters must remember what are the types of splints we have to stabilize the fracture, and sometimes even in treatment. Traction, extremely important. Balanced traction, Russell type of balanced traction, very important. Patient, if it is a fracture like this, you can keep it on a pillow or apply a traction. Fixation is not a healing, as I said. Remember, any type of fixation is not directly proportional to healing. There are many, many other factors that, and the only thing is caring for the patient. A role of industry is very important. We are grateful to the industry that it has helped the specialty. But there is a big but behind it. And we all know about it. Excess of everything is not so good. I am not against the industry, I am for the industry, but they must know where to stop. That Lakshman Rekha has to be remembered. We follow the foreign journal, just 1 minute, Mr. Chairman. We follow the foreign journals and articles like Gita and Bible. Sir, it was quoted there. In every hall, everywhere, I also do it, you also do it. But there is a lot of Professor Carr and others of the Oxford University. It is mentioned in the JBJS American. Which research is to be believed? There are questions from them only, and too much of fabricated and manipulated research. Morris Muller, Switzerland, millions of dollars were spent into the efforts which, however, never brought out the concrete benefits. So, we are people having wisdom, and we should avoid the catastrophic consequences. There may be wonderful success, but miserable failures. We should, orthopedic technology may change to any extent, but the goodness of a doctor must not change. And we are all people with wisdom, and if we remember, we are number one when we got admitted in medical college. But that wisdom must be retained for all times to come. Indian Orthopedics Association, I would request, if the office bearers are here, there should be a website that there should be a mention of role of conservative mechanism in orthopedic surgery so far as fractures are concerned. So we should have individual efforts and collective efforts, and then only we can overcome all these facts. So basics must be learned, and challenges are not yet over. We are still fighting. Who will guard the guardians? This is a message from Massachusetts, USA. As Professor Carr said, which research is to be believed? Because there are many fictitious researches. So, last slide. Conservatism is a biological necessity. Let us learn and relearn the art. Friends, you will enjoy it, because unless and until you have seen the results of close reduction, you cannot compare it with the open reduction, which may not be as good as. Remember that the bad results of open reduction and internal fixation, as you saw just now, are much worse than the worst results of closed reduction. And I think with that I will stop, because common good I have allowed. Now, will it happen? That's all. This is the last sentence. Will it be allowed to happen? Reason may be any or many, but will it be allowed to happen that we learn the art of close reduction? You will be hearing the stalwarts from the country, And thank you very much for your patient hearing. Now, Professor Tuli.
Next speaker is another doyen of Indian orthopedics. He will share his experience on the healing in closed fractures.
Cascade of healing in closed fractures. Professor Tuli, please.
The guardian should guide the timetable.
Thank you very much.
Chairperson, sir, learned audience, I'm basically on the basics. Fractures have been healing since the man or animal reached the earth. And why do the fractures heal? I think the basics are, bone is essentially a blood vessel. I think if we can remove all the hard material, there are many methods of doing it, remove the mineral, the matrix, and this is the appearance of a bone. The bone is a blood vessel, it's just surrounded by the hard tissues. If we can respect this blood vessels or circulation, the bone should heal. The bone has the potential of self-regeneration. For generations, we have been taught that bone is the only tissue which has the potential for self-regeneration, and the repair will take place by the formation of bone. But now, with newer technologies, many other tissues are also being shown that they can repair by the formation of the original tissue itself. Whenever a fracture occurs, what happens? Bone, a blood vessel, it bleeds. There's a bleeding endosteally, periosteally, and all the vessels which are contained within the substance of the bone, and also the soft tissues beyond the that's the problem here, beyond the periosteum even. And this blood collects around the site of the fracture, which has been conventionally called fracture hematoma. Today we like to call it substrate for fracture. It is this fracture hematoma which is going to be converted into different materials depending upon the environment which we give to them. If we don't give good environments, it's for us to give the environment. If this place is going to shake like a milkshake, it is going to form the fibrous tissue. If you want to get it infected, the same cells will get converted into infected material. If you give excellent environments, it will form the bone. The fracture heals by not watertight compartments, but by overlapping compartments. See, something like a fracture hematoma, the substrate which gets converted into a mineralized tissue. Earlier stages, soft callus, mineralization of the callus, callus consolidation, and callus remodeling. These are not watertight compartments, they are overlapping compartments, and here we see the overlap. The expression of matching the overlaps is inflammatory stage, repair stage, remodeling. And you can see angiogenesis is occurring in the inflammatory stage as well as in the repair stage. Substitution is taking place in the repair stage as well as in remodeling. So these are overlapping or cascadal phenomenon. Whenever a fracture occurs, it stimulates the repair. What is the triggering factor for repair is an injury to the bone. It's a fracture, an osteotomy, an injury. The moment the bone is injured, it triggers the cascade of repair. And the first thing which happens in the triggering is so-called mesenchymal cells. And these mesenchymal cells, they are almost like an army. Bone is injured, an army of mesenchymal cells are produced. It is for you to convert this army into osteoblastic cells, or fibrous tissue, cartilage cells, or infected material. So it is for us to offer the best of environment to it. And in the initial stages, There is, in the first week, there are only non-specific inflammatory cells. In the second to fourth week, these very mesenchymal cells, they get converted into sort of a mixture of osteoclastic cells and osteoblastic cells, and this is a clump of osteoblastic cells. We have been talking, or all of you must have been reading about this so-called cutting cones. Cutting cones is nothing else but a large vessel. It's a large vessel which is headed by multinucleated giant cells, which can be called osteoclastic cells, but this is the large vessel. And this large vessel is lined by osteoblasts. The first new bone formation after any injury of the bone is going to be around the blood vessel, the so-called neo-osteogenesis. So encourage the neo-osteogenesis. This is sort of a neovascularization, perivascular neo-osteogenesis. Every new bone that forms is around the vessels. We will see another picture, which is from our experimental work. At some stage we were doing experiments on rabbits regarding fracture healing, and see the number of blood vessels that form. This is all neo-osteogenesis. Give them tetracycline and you can realize that this is the first layer of neo-osteogenesis. Then this would be, after a gap of 2 or 3 weeks, a second layer of neo-osteogenesis, and these large vessels ultimately get converted into osteones, or smaller areas. Here is an example. This was the bone which laid down in an animal. This was the bone which laid down, say, 30 days ago. This is the bone which laid down 20 days ago, and this is the bone which was laid down only 10 days ago, and this is a large vessel getting converted into an osteone. But these are the standard methods: callus formation, hard callus, reformation of the medullary canal. The medullary canal reformation will take many months to years, depending upon the Wolff's law. Again shows the same thing, that once the bone breaks, there is a fracture hematoma. A 1 to 2 millimeter of bone at the side of the fracture undergoes necrosis, which is taken care of by the osteoclast, which ultimately get replaced by neo-osteogenesis around the neo-angiogenesis. If you look at different methods, broadly speaking, there are 3 methods of taking care of the fractures: closed method, plate method, intramedullary. Which one disturbs the fracture hematoma or the fracture hematoma substrate in different ways? In closed ones, the substrate is not disturbed at all. Mechanical stability is fairly good. Fracture hematoma is least disturbed, and one mechanical thing which has been shown to be having a positive effect on fracture healing is cyclical loading, which you can easily do on a suitably applied plaster of Paris, and you can also do it in suitably performed intramedullary nail, though it is delayed in plates. This almost gives you an idea that closed reduction gives least disturbance to the fracture hematoma or the substrate for healing. I think one should consider that Charnley as a role model for an orthopedician. So you look at Charnley. On one hand, he writes a book, Closed Treatment of Common Fractures. On the other hand, he starts writing on replacement of joints. So this is Charnley, and that is what should be a role model for all of us. We should be able to treat certain things by closed method and other conditions by even large operations. Most of the fractures in children unite, children up to the age of 12 years, most of them will unite without surgery, and most of following fractures will unite in adults without surgery. So like in adults, clavicle, proximal humerus, mid-shaft humerus, distal radius, distal shaft, tibia, and shaft tibia, ankle, metacarpal, metatarsals. Closed treatment succeeds in many, even recent osteochondral fracture. If we have the facility of a C-arm, majority of the fresh osteochondral fractures can be reduced to a satisfactory position, and if you can hold them by percutaneous K-wires, it is almost like a closed reduction. We are only improving the quality of closed reduction in osteochondral fractures. The only thing is that when we put in K-wires, it should have a biplanar fixation and bicortical engagement. Here are a few examples. A grossly comminuted osteochondral fracture of the upper end of the tibia, treated by multiple K-wires, closed reduction, and see the I think it's a very good healing, maintenance of the joint space, and fairly good range of movements. The fracture hematoma or the substrate has not been disturbed, so you can get a quick healing without any extensive operative procedures. Same thing can be obtained in the lower end of the humerus. It's a grossly comminuted, displaced fracture in a lady 65 years of age who has multiple comorbidities. Closed reduction failed, under C-arm reduced, put in multiple K-wires, and she got a reasonably good outcome. Similarly, upper end of the humerus, fractures of the upper end of the humerus can also be treated closed in a C-arm, and you can hold these fractures with multiple K-wires with bipolar bicortical engagement. Too much of implant does not necessarily mean that the fracture will heal. Sometimes we get into that impression that I must use multiple screws, multiple plates, something like cobra plates, which have been given different names. It does not necessarily mean that the fracture will unite. There was a tendency to sell primary bone healing. Professor Yadav mentioned, but I am quite fond of reminding us that we were sold this technique of so-called primary healing. They converted the natural healing, they denigrated the natural healing to a secondary healing. They thought the primary healing is the primary healing and there is a secondary healing. This sort of a denigration to a natural or a callous healing. In rigid fixation, so-called rigid fixation, the indication was every fracture is an indication for rigid fixation. And what did it do? Aim at no motion at the site of the fracture. If there is no micro motion, no callus will form. If there is no micro motion, no callus will form, and judgment of union is always uncertain. Refracture is not an uncommon thing in so-called primary healing at the implant bone interface or because of load or stress shielding. People of my generation had opportunities due to some reason or the other removing those rigidly fixed implants. And you could see under the plate the bone is ivory white. There is no circulation there. But on each side you could see the normal bone, and the plate, at the side of the plate, the bone is atrophied and marble white. And many of times these patients did have a fracture while removing the plate or even after the removal of the plate. If you read the literature, even there it is described. If you remove an implant in a rigidly fixed bone, you have to protect these limbs for 3 to 6 weeks, lest you may get a fracture. I think time is up probably.
Yes, 1 minute more. You can.
Here is an example of a fracture at implant bone interface in a patient who had undergone a so-called rigid fixation. Sir, bone for its repair needs not the technique of a cabinet maker, but the patient care of understanding of a gardener. This is written by Girdleston. Let's be wary of the jet set evolution of surgeons who believe that for every orthopedic disorder, operative treatment gives the better result. And then with the operative treatment with implant fixation, the result is further better and beneficial. This picture shows you the collection of osteoblasts and an osteoclast. It is for us to provide environments to the multifaceted reparative mesenchymal cell, the army which it produces, converting them into osteoblastic cells, fibro tissue are infected. Thank you, sir.
Thank you, Professor Singh.
Next speaker, Dr. Rajiv Naik is present. I will request Dr. G.M. Khare to present the paper on conservative treatment of fractures around elbow.
Good afternoon, everybody. First of all, I'm grateful to Professor S.S. Yadav for selecting me to present my work here, and I hope I will come to his expectations. Injuries around elbow are very common in children. Whenever a child falls, we get injuries because of fall on the outstretched hand. And among these injuries, supracondylar fractures constitute the majority, as you can see here. And children also have got different carrying angle, which we studied by measuring carrying angle of school children to correlate these fractures. Supracondylar fracture was a most difficult fracture when I was resident to treat, because cutis varus was the most common complications. So I studied it, tried to study it in most detail once I passed my MS, and we measured these carrying angle in school children in various age, from birth up to maturity, to study how the carrying angle develops and how it changes. So we found that at birth it is carrying angle is in the valgus, but during the growth period it fluctuates. And sometime it goes even up to minus. Some children may have carrying angle -2 degree, -3 degree also. So this was the final curve for boys and girls. Some children, they have -5 degree also. And I'll later on correlate these angles with the fractures and its significance. So many authors, they measured the carrying angle, and we found that it was more in females. And our findings support what they have observed. But whenever a child falls on outstretched hand, it is the carrying angle which determines what type of fracture a child gets. So around 7.5 years, supracondylar fracture is seen most commonly, because carrying angle is in valgus. So children are born with valgus carrying angle, which fluctuates too much. And lateral condyle fractures are seen in children having Barrett's or neutral carrying angle. That was our observation clinically. And supracondylar fracture was seen in children having valgus carrying angle. So around 3 to 6 years of age, the carrying angle is it Barrett's. That is why children, they often get lateral condyle fractures. And around 7.5 years, it is valgus, so they get supracondylar fracture. And this is the common mechanism, fall on the outstretched hand. And we also observed why there are two types of supracondylar fractures. Literature says it is because of fall on the point of the elbow. But we took detailed history. We also observed the abrasions, whether they are on the palm or they are on the elbow. And we found that the supracondylar fractures, two different types, are not because of fall on the point of elbow or outstretched hand. They are because of different rotations. It is a rotational fracture. So whenever a child falls anteriorly, when he is playing or running, he will get medial rotation. He will fall anteriorly, and commonly they fall anteriorly. That is why 98% fractures are extension type, posteriorly displaced fractures. And whenever they fall, there is posterior displacement, there is medial rotation. You can see the large fistale sign indicating rotation. So supracondylar fractures are rotational injuries, and they are oblique fractures. Most of them are oblique fractures. But when a child falls posteriorly, like when they fall from carrier of a cycle, or somebody is swinging and he falls posteriorly. And these children, when they fall posteriorly, they get displacement which is different. They get lateral rotation and there is anterior displacement of the fractures. So after observing many hundred of children, making careful observations, we have proposed a new hypothesis. This paper and this hypothesis is published in the Journal of Pediatric Orthopedics, B, which is published from UK. And this is the fracture which the child gets. You can see the spike goes posteriorly. There is opposite rotation. When the child falls anteriorly, this spike goes anteriorly. So it is a rotational injury which determines which type of fracture we get. And this cubitus varus was the most common complication of supracondylar fracture. I observed that even despite of treatment by the most learned orthopedic surgeons, many children used to get this fracture. So you can see many children coming at the same time for treatment. The fracture is very common and the complication was also very common. So this made me think that something is wrong which we are not understanding properly, why these children get cubitus varus despite of best treatment. And at that time, we used to correct them by corrective osteotomy and applying plaster cast in extension. So many children. So I performed cadaveric experiments to know exact mechanism. What causes cubitus varus deformity in supracondylar fractures? And we made experiments, created fracture, and then I divided different muscles in different cadavers. And supination used to cause opening laterally, and pronation used to close the gap. So it was confirmed that it is the pronation which is better position, which can prevent cubitus varus deformity. But why? Why pronation? How it works? So we divided different muscles one by one and supinated, pronated each time. And we found after doing experiments on many cadaveric studies that it is the triceps muscle which is the culprit. And this is the supination. We confirmed the findings in children having open supracondylar fracture who came to us after open supracondylar fracture. Supination opening the gap, pronation closing the gap. You can again see supination opens the fracture gap, and when we pronate, it closes. So we confirmed the findings on living children also, not only on cadavers. And this is the mechanism. We found that triceps is the triceps is the main deforming force, and it is eccentric compression of the triceps. It is the seesaw action of the radius in ulna which prevents the varus. So a new mechanism was described. This was the position which children were immobilized, and we propagated that it should be position on the lateral aspect of the chest, not on the front of the chest. And this is the crescent sign. This is the fistale sign. These are the results in some of the children. We treated conservatively, and we had excellent results in the majority. And many of these fractures, if we cannot reduce their soft tissue interposition or too much swelling, then we have to put the closed Krishnar wires. But even after Krishnar wire fixation, the fracture are not always good and stable. Say this is example, a fracture, supracondylar fracture, treated by 2 Krishnar wires and looking good postoperatively, but later on this wire came out and the child developed cubitus varus deformity. We had to do the corrective osteotomy, and this is the final results. So the message is that even after K-wire fixation, if we can put the limb in pronation and the wire comes out, the child will not develop cubitus varus deformity. So pronation is a must for prevention of cubitus varus deformity to prevent it. And we also demonstrated for the first time that in these children, supination is exaggerated and pronation is restricted. No book mentions this, but mentioned this before. But this was the finding which we observed for the first time. These are the cubitus varus deformity cases which we treated. And I will see. These are the patients who had vascular injury, and they also had good results. We treated them by K-wire fixation, and the vascular repair was not done, but the limb survived despite of so much injury, because there are good collaterals around the elbow. So if you do not have facility for vascular repair, you can still treat them because good collateral circulation is present. Another same child, after healing of the fracture and his limb. So this shows the collaterals around the elbow. Another case, having vascular injury, his limb also survived by conservative management without any vascular repair. Some new types of TY fracture were described by us. Here I will show one important case of fracture of humerus. This patient came to me after 2 years, and he was having this much gap and very small discharge. There was a small sinus present. What we did is, I just removed his plate. I did not do any internal fixation or anything else. I did not repeat any, and he was kept in plaster in pronated position. Here also the same mechanism works. The triceps tendon compresses, and see the result, the fracture united without any internal fixation. So thank you very much. The message is that conservative treatment is good for injuries around elbow in children, in adults also, for fracture shaft of humerus. Majority of them can be treated conservatively if we keep the limb in pronated position, because the same mechanism works for humerus also. The triceps becomes tight and the ulna shifts medially in pronation. So thank you very much for your kind attention.
Thank you, Dr. Kare. Next speaker is Dr. Agarwal. He will speak. Dr. Agarwal is here. Yes. He will speak on the management of fractures.
Good afternoon to you all, my teachers here and my learned colleagues here. I shall be speaking on fractures, conservative treatment. I shall be speaking about fractures around the wrist, the conservative or the non-operative treatment of these fractures. And I am substituting here for Professor Dr. Mukund Lal, who could not be present here. I hope you, Professor Yadav, would permit me. Thank you, sir. If you look at the radiological anatomy of the wrist, just a recapitulation of what we already know. This is the common fractures that we see around the wrist of the distal radius, ulna, scaphoid, and then scapholunate dissociation. So these are the common ones. Out of all injuries around the wrist that we see, these would probably account for most of the injuries. And out of all fractures that we have discussed till now, I think the distal end of the radius is one where the controversy is the maximum. Should you operate or should you not? It accounts, I'll start with the distal radial fractures first. It accounts for about 16% of all fractures in all gender and age groups. The peak remains females or ladies after the age of 40 years that are insufficiency or osteoporotic fractures. And then we have age group in children, which is 5 to 14 years, usually called the adolescent fracture. Of course, the treatment for adolescent fracture would be totally different. It is conservative, as we all know, and we all have done it, and we have got very, very good results with that. So there is hardly any need, except for maybe a small proportion of compound fractures. There is hardly any need to intervene. The second group is males. Under this we are seeing now more frequently because of high energy trauma or high speed road accidents. We are seeing a lot of fractures in males who are under 50 years of age and who have very difficult fracture patterns of the distal end of the radius. Here also I would say operative treatment is gradually overtaking conservative treatment for a variety of reasons. There is hardly any controversy in the last group. Majority of us have, and I think would continue to treat these fractures conservatively. What are the risk factors for an osteoporotic fracture of distal end of the radius? A female gender, ethnicity, hereditary, and early menopause. The other names for distal end of the radial fractures is Coley, Smith's. We all know that. These are examples of some of those. It's a Schoffer's fracture of distal end of the radius. Coley's fracture. Most common age group is 60 to 70. Women are the ones who are most frequently affected by this fracture. 90% caused by compression on dorsiflexed wrist, and 90% of distal radial fractures are Coley's fractures. This is the usual mechanism of fall, and this is how it looks like. What X-rays do we need to order when we see a patient of this fracture? A PA view, a lateral view, oblique views, tilted lateral views, sometimes traction views, X-ray of the contralateral normal wrist so as to define the fracture pattern, and very rarely do we require other studies like reconstructive CT scan or 3D reconstruction, CT image, or very rarely an MRI. What do we want to look at in these image studies? We want to define all these parameters, the dorsal or the palmar, palmar tilt, radial length, ulnar variance, radial inclination, and carpal malalignment. If you look at the X-ray down, you can see the distance between the radius and the lunate appears, the scaphoid and the lunate appears to be slightly more. So there might be some ligamentous injury in that region in this X-ray. How do you classify these fractures? There are a number of classifications: Fernandez, Gartland, Frickman, Malone. Malone is the one who defined distal and radial fractures in terms of columns, like defined, the AO group defined the distal end of the humerus. So we have a radial column, a ulnar column, a dorsal and a volar column. And then we have and the AO classification, which is quite comprehensive. How do we decide what to treat? So the treatment rationale depends upon the palmar tilt, the radial length, ulnar variance, radial inclination, carpal malalignment, and intra-articular incongruity. Acceptable radiological parameters for this fracture: radial length within 2 to 3 millimeters of the contralateral side, palmar tilt neutral, intra-articular step less than 2 millimeters, a radial angle loss of less than 5 degrees, carpal malalignment should not be present. How do you assess the stability? Initial dorsal angulation of more than 20 degrees, dorsal metaphyseal combination. These are all factors which define stability of the fracture. If they are present, most likely it is an unstable situation. Intra-articular involvement, associated ulnar fracture. All these define a relative instability of a distal radial fracture. How do we decide what to treat? Level to which anatomy can or is restored, quality of bone, emergence of new techniques and devices. Devices, I would say implants particularly, especially the locked angle devices which have recently become available, and experience and ability of the surgeon. I am firmly of the opinion that before we have done our 50th case, we are still a learner. So, and there would be very few amongst this audience who would have done at least 50 distal radial fixations till date. I mean, I'm very sure there would be some who might have done it, but majority of us would not have reached that 50 mark. And unless we have done at least 50 surgical procedures, the experience is still borderline. We are still learning. Of course, we continue to learn throughout our lives, and of course, outcome in older populations. We have to be fairly certain that in older population, you may accept a degree here and there more because the demands are less. Non-operative treatment is very good for these situations, stable fractures and low demand patients. Of course, today we cannot say that any patient's demands are less. Close reduction and cast immobilization. What are the indications for this particular treatment modality? If the fracture is extra-articular, less than 5 millimeters of radial shortening, dorsal angulation less than 5 degrees or within 20 degrees of the contralateral side. I think we have already discussed this. The operative treatments are many, as some of the speakers before me have also told us, that possibly percutaneous fixation or percutaneous K-wire pinning of fractures would be just an extension of the closed treatment method. So percutaneous pinning, close reduction and percutaneous pinning of distal radial fractures, bridging or non-bridging external fixation of these fractures, and then of course we have open reduction and internal fixation with a number of implants that have recently become available, the majority of them being locked devices. And then we have arthroscopically assisted reduction and external fixation, or arthroscopically assisted fixations also, and a combination of any of these techniques. Close reduction and POP cast immobilization, what are the advantages and what are the disadvantages of this particular thing? As you can see, the slide down shows a malunited Colles fracture, because we see the prominent ulnar, the distal end of the ulna appears more prominent, and there is a radial inclination of the wrist and hand. Most extra-articular fractures can be treated conservatively, and we have about 90%, if you want to be conservative, 82% good result if the technique is used appropriately. What are the disadvantages? It requires a very close monitoring, which means for the next 3 weeks the patient needs to visit you practically on weekly basis, so that you can try and pinpoint those fractures which displace in a cast as the swelling comes down. And the other disadvantage sometimes is a fracture disease now called CRPS, that is, in the past we used to call it the shoulder hand syndrome. The fracture unites beautifully, but what happens? The wrist is stiff, the fingers are stiff, the elbow is stiff, and the shoulder is stiff. The entire upper limb is stiff and the patient is in tremendous pain. And then there are the others, carpal tunnel syndrome, which is more appropriate for a fresh fracture, and in a delayed fracture we can have the rupture of the extensor pollicis longus. Close reduction and percutaneous pinning as a method of closed treatment of these fractures. The advantages are it is minimally invasive, it maintains the sagittal length and the alignment in extra-articular fractures which have a stable volar cortex. So possibly this technique would be good if you have a good volar cortex, which means there may be combination in the dorsal cortex, but the volar cortex is intact. And again, the results are fairly appropriate, fairly good, I mean, it's about 80 to 90%. What are the disadvantages of this particular technique? It requires additional support, which means we can't do away with the cast for some of us who don't like the cast any longer, or many patients also now say, I don't want a cast, you just give me something that doesn't require a cast. If we cannot maintain, or if there is unstable or comminuted volar cortex, again this would not be a good technique to treat these fractures. It cannot be uniformly applicable for all fractures, because in very osteoporotic bones the pins just do not hold. There are of course a significant amount of complications associated with these pins itself, in form of infection, migration, loss of reduction, and sometimes you may have neurovascular complications on account of pin insertion. External fixation, advantages versus disadvantages. This slide has been borrowed from, I think, one of the textbooks. It neutralizes the axial load on the distal radius during normal physiological activity. What are the disadvantages? Again, you have a large frame on the outside. It is cumbersome to maintain, pin tract complications. There may be stiffness of finger, especially of the index finger, because of lack of effort on the part of the patient in the post-operative period, or we may have impaled the extensor tendon while inserting the pin. And the last method of treatment, of course, is as shown above. These are the volar lock plates. Their indications, as I understand, would be most appropriate for volar Barton fractures and for young patients. For young patients who have a very comminuted fracture of the distal end of the radius, intra-articular extension, significant articular displacement more than, we said 2 millimeters was acceptable if it is more than 5 millimeters. Yes, sir. These are again comparing the open reduction with plate osteosynthesis. This looks good, but this is what happens. We started with this. The post-operative X-ray looks fantastic. The wound has healed good. The scar appears good. The range of movement in the immediate post-operative period, 6 weeks, 3 months down the lane, looks very good. He can squeeze a ball also and then see what happens. So we have to be careful about these complications. As the first speaker, Professor Yadav, rightly mentioned, we must know which technique to use in which patient. And I think that is the gist of the this discussion today, that conservative treatment is not for older generation of orthopedic surgeons. It is for all of us. Thank you, sir.